To Dr. Jeff Atkinson, and he is the Assistant Professor of Medicine in the Pulmonary Division at Washington University, also here in St. Louis, Missouri, and also the Medical Director of the Pulmonary Function Lab at the center. So welcome, Dr. Atkinson.
All right, well, thanks for having me today. I really appreciate coming here, and I'm glad that Jeff got to describe all the liver processes because I think that's the hard part. So I'll go through all the rest of this in the next 30 minutes. So hopefully you can understand it through the way I look at it. I have no disclosures related to this. I do receive funding from the NIH to study emphysema, and then I've been funded by the Alpha-1 Foundation in the past. I am a co-investigator in the SPARTA trial, which is funded by Grifols and Washington University, receives payments for that, but I'm not currently getting any funding from it. And I work for the Alpha-1 Grant Review Committee. So I want to give a presentation, kind of describe a case or a presentation of somebody with their lung disease, relate the symptoms of the disease to the lung function testing you get, and then relate the symptoms and the testing to what happens in the lung itself, and then discuss how treatments relate to those disease manifestations. So I chose my patient to be Mr. AAT. I guess you can imagine where that came from. And essentially, Mr. AAT came with symptoms of feeling short of breath with minimal activities. It took him a long time to accomplish a simple task, and he found that he needed oxygen even to walk short distances. And in relation to that, why does Mr. AAT have these symptoms? Why is he ill in this way? So the first thing that happened to Mr. AAT is he got lung function testing. And this took about 45 minutes. He walked out with a sheet of paper that left him puzzled as to what it meant. And certainly the thing that he could see is that, I don't know if it projects as well as I'd like it, the normal curve is here, and he is here. Obviously much smaller, shifted over to the left. There are some numbers that clearly looked bad. See, it's 29% here. Up here, it's an 18% or a 19%. But there's some numbers that actually look like they're bigger. Why isn't that better? This number, he's 130%, and this number is 340%. Certainly there's something going on, and there's a problem. They drew his blood, and they took his oxygen, and his oxygen was normal when he's sitting at rest. And I told you before, he's short of breath when he exercises, but why is his oxygen still normal? So the first thing is that just because things are bigger doesn't necessarily mean they're better. And that's part of the problem with emphysema. These are chest x-rays. And if you think of a chest x-ray as showing someone that has tissue which is white and air which is black, the lungs, which are mostly filled with air, always show up as black. And you would think if you had a bad lung disease, you could see it easily on the x-ray. And that's part of the problem with emphysema in general, is that people get x-rays and the x-rays look normal. Or people, have smoked for a while and they say, well, your x-ray shows emphysema. You really can't see much there, and that's why the lung function testing helps us so much. What you do see in this x-ray is the fact that the lungs are bigger. And part of that, you can see that this diaphragm and this diaphragm here, they're supposed to be shaped with these curves, and instead, they're pushed down and they're fairly flat. It's a little easier to see it on the side view. But again, a normal person has this nice beautiful curve of their diaphragm because the muscle works. And here it's very, very flat. The chest becomes round and almost barrel-shaped, filled up completely with air. And that's what happens with emphysema is that you fill up that chest completely with air. Yeah, it really didn't project well. So it's a little easier to see what happens in a CT scan. And this, again, gives you the same picture where you've got lung areas. You've got tissue, which shows up as whiter, and air, which shows up as darker. And when we look at a CT scan, we're literally looking at slices through a person, kind of looking up from your feet towards your head. And these are serial images as you go down the body, from up high towards the neck almost, and then down to where the bottom, where the heart is. And the CT scan shows a little more of what's happening in that where we've got nice kind of even tissue throughout, we've got these areas that are black. And these black areas are actually holes. But the other thing that I wanted to talk about today, or they had asked me to talk about, is what we call bronchiectasis. And bronchiectasis is literally airways that have gotten big, and they kind of look like this, where there's this circle here, and there's this little smaller circle there. This little circle is a blood vessel, and this is an airway. And they're supposed to be set up in a way that the normal, where the blood vessel is bigger than the airway, and for some reason they get big and large, and they are easier to see, which I'll go through the project up. So again, here's emphysema. There's areas where there should be tissue, should be whiter, and they're completely blacked out because it's all air. And you can see they come in even little circles in the middle of areas that look normal. And then here's the bronchiectasis. This airway is larger than the vessel, and it has this kind of whiter edge of its wall compared to the normal airway where you can barely see them, and the vessels are much bigger. So what happened when he walked? When he started off, he was doing fine. So this is on room air, and his sat actually dropped even when he got up to stand. As he started to walk, and he walked a fairly minimal distance, this is 6 minutes total, got up to 969 feet. Every step, oxygen levels went down and down and down. Heart rate went up as it should, blood pressure went up as it should. When he rested, they repeated the lung function testing. He's still fine, but immediately on standing and on walking, things got worse and worse and worse. Why is that? Why would it be such a big deal to get up and walk? Eventually, he did get alpha-1 testing. Unfortunately, we see this when it's easy when they have severe disease and 46 years of age. It's harder when you don't fit that phenotype. But even under this case, it was late, severe disease by the time the testing got done. So here's what happens. So alpha-1 is made in the liver, and I'm sure you got that full story already. It goes out in the circulation, and what it does in the circulation is it passes through your body and it kind of bathes all of your organs. When you have something that is irritating, smoke being a common process, this irritation causes your cells to release enzymes. And those enzymes, particularly elastase, come out and they get sucked up by the alpha-1. Literally, it binds to it, it gets clipped, it stops it from acting. And so all of this elastase that's released gets disabled by the alpha-1 permanently. And when the alpha-1's there are elastin cables holding up your lungs, and they're protected because it's there and it stops the destruction. If you don't have the alpha-1, you get the exposure, smoke, something in the environment, the elastase is there, and it can actually take those elastin cables, cut them up, and break them into little pieces. And it's almost even worse than just the fact that they're being cut up, because the broken products your body sees as abnormal. Otherwise, infections and things like that will result in broken products. And so it's your body's response to recognize these broken products and go back and have more inflammation and make more elastase. And so you end up even getting a cycle that you don't even need the smoke as much to push it through and break down more elastin products. So what is the elastin doing? I like this representation, because if you think of your lungs as being held up like a pup tent, in the old pup tents you had a string and you had stakes in the ground, and it was held up just by the tension of all those strings and everything pulling on each other. If you think of the strings in the pup tent as an elastin cable that's present in your lungs, and if we clip this elastin cable, you know what happens to the pup tent. It all just collapses right on itself. And so just clipping the elastin cables causes these areas to break down and makes them non-functional, just like that pup tent will flatten out. Okay, so this is what it ends up looking like. In a normal lung, you've got a lot of small spaces. So this is a cut, dried surface of a normal lung. Sliced through, you can see there's a lot of little small spaces. These little small circles are where the air goes in and you breathe. And when you break up those areas, you get these big, huge spaces that obviously there's many more spaces to exchange gas here than there is there. And you can see the stretch that if this pulls, it's not pulling the same on all the different parts as that will. So why is that a problem in the lungs? Well, the purpose of the lungs is just to bring oxygen in. And you bring the oxygen in, you get it to the blood, and then it can be delivered to the rest of the tissues. The lungs are a constant exposure. So whatever you do, wherever you go, you're going to breathe in the stuff there, whether it's things you inhale at work, whether it's other things. Your lungs are in constant exposure. Therefore, the inhibitors have to get to the lung. And you need to get concentrations over the entire surface of the lung, which is very large. You talk about if you stretched out all the breathing spaces, you get a tennis court's worth of lung. And so all of that stuff in your serum has to stretch out. And the bases are the largest part of the lungs, and this is typical in alphas, that the bases get affected if you think of it's the biggest surface area. Finally, the big problem is that it's a delicate structure that's constantly moving. And so if you can't protect a large surface of the lung, it gets destroyed, it's unable to repair itself because it's moving constantly. These are scanning electron micrographs. So this is a very blown up picture of what the lung normally looks like. And if you look at it, there are these very small breathing passages that the air passes through to fit into these little sacs, which is where the blood exchange occurs. And so the oxygen has to come in through all of the breathing passages down to the very small ones. And if you look at it, it almost looks like a fiber of a sock. And that's really the way the lung works, like a good silk sock, that you pull it over your foot, you put it on, and it takes that shape of your foot, and when you pull it off, it collapses back to its original shape. When you get destruction, when you get emphysema, you can't get that ability to go back to that small shape. So here, you can see there are some areas that look pretty normal in comparison to that, and then there's the big stretched out shapes. But when you look at the airway, they're all actually touching, and they're all actually connected to the airway as well. So it's not just the destruction here that's the problem, it's that you've lost this kind of delicate connection that was pulling and stretching like that sock to fix it. And so in a diagram, if you think about it, those small sacs are here, that they're stretching in these elastic cables that are really just the other alveoli to the side. But they're also pulling on this, which is the space the air uses to exit. So it's the airways where you breathe out. And that pulling keeps the airway open. So when you get destruction here, it does affect this, but it also is a problem there, that you're not getting that pulling force to keep the airway open. And when that happens, this airway actually collapses on itself. It gets a lot more resistance. There's less air that comes out. And you actually get, from that irritation, can get more mucus, which worsens the process. It narrows it even further. The mucus is because it's irritated and you've got all the extra resistance. But just this breaking, the stretching, causes the whole thing to collapse. All right. We always simplify things. We're always describing how things work. We always simplify things. We talk about how elastase is a problem, how alpha-1 is an anti-elastase. It's much more complex because there are a lot of other proteins that elastases do digest. It's multifunctional. It's meant to be that way. It's there so you can fight off infections. It's supposed to eat up bacteria. The cells pick it up and they eat up all kinds of parts of the bacteria. But it also destroys other proteins. And those other proteins can be structural, but they have other functions too. And we're always finding more and more things that go wrong. And some of them are because these other proteins that are not the elastin also cause issues. And that's why when we talk about where else is there damage, it's not just the elastin cables in the lung. Certainly, some of those proteins are going to result in problems, more mucus, more disease of the airway, but also the upper respiratory tract. So if you think about your respiratory tract, it really is tip of your nose down to the bottom of your lungs. The same process is going to occur the whole way through. And so people with sinus disease and excess mucus in their sinuses, it's also related to the fact that there are things being broken down, enhancing the inflammation and causing more mucus and more problems. Some of these things probably have an enhancement in the immune response. And so some of what we know about allergic responses and things in alpha-1, there's probably even more information we're going to come out. Yeah.
Oh, finish
Yeah.
your sentence. I was just wondering, because of the sinus and nose area you're talking about, is there tend to be an increase in like sinus infections and those kinds of things?
Right. So what we think of again is that there's enhanced inflammation. So there's excess kind of inflammation the whole way through, and because of that, people can get more sensitive to things that would normally happen. And so if you have bad allergies, and you have a problem with alpha-1, you're probably going to have enhanced amount of mucus that's being produced from that same allergic response. The treatment is still fairly similar in that you'd want to avoid the allergen if you can and try to decrease the inflammation. But you're going to have more mucus probably from all of that. And so it is going to enhance whatever problem you have because that mucus is there. And so often the other thing that helps is if you have bad allergies and you have alpha-1, is trying to get that excess mucus out. So washes and things like that, because you know there's going to be more mucus than there would be in somebody else. But yeah, that's exactly the point. I think I have a slide that discusses that when I get there, but that's exactly the point, that if you have a problem, if you have allergies, if you have sinuses, you're going to get an increased problem. And the way you get sinusitis really is just it gets plugged with mucus and the infection gets behind the plug. And that sinusitis, that pain and pressure is all just plugged up. Okay, so bronchiectasis. They had asked me to put in, lung disease, including bronchiectasis and sinuses. And I admit, I'm a lung doctor and not a sinus doctor. And bronchiectasis is something that I can talk about a little easier. Literally, it means that the airways where they're supposed to go out and become small and taper fail to do that. They end up being very large, and they have a tendency to be filled with mucus. If you look at a normal airway, it has a muscular wall, it has a thin layer of mucus above the epithelium, and then there's an open center for all the air to pass through. When bronchiectasis occurs, it means there's damage to the airway wall. The airway gets bigger and larger and stretches out, so this kind of failure to taper. But it also ends up getting filled with mucus. And so it's a big problem in that the mucus fills the space and there's not as much space for air as well. So it's both destruction of the airway wall and it is injury of the cell's lining. And the result is that there's mucus there that needs to come out, causes it to collapse because there's more resistance. It probably is a result of chronic exposure to inflammatory stimulus and damage to that airway wall. But it also could result from severe infections. And I think we're finding, from other diseases where people get severe pneumonias and don't have great protection, that you can get bronchiectasis. Clearly, the thing to do to avoid that is to try to avoid bad pneumonias. And this is relatively easy and relatively straightforward. Flu shots do work. They prevent people from getting the flu. People that get severe infections after the flu get bronchiectasis, whether they have alpha-1 or not. Pneumonia vaccine, it's effective. It doesn't prevent every type of pneumonia, but it's an easy thing to do. And preventing the bronchiectasis that could occur in anyone with alpha-1 deficiency probably is avoidance of severe pneumonias any way we can. And these are good ways to do it. Once people develop bronchiectasis, that mucus is there, it needs to be cleared out. Exercise is usually the best way to clear mucus. I don't know if anybody has ever done this, even people that are healthy. You run for a little bit, and then all of a sudden you have to cough, and you're like, ugh, it's not when I'm running, it's when I stop running, I have to cough. And literally all you're doing is you're clearing the mucus that's there. Regular exercise, even if it's brisk walking, is a good way to help you clear out the mucus. For people that have bronchiectasis, that have that excess mucus, regular exercise or other ways of kind of clearing it out are what you need to do to keep those spaces more open. So this is what I said before. It's not that deficiency of alpha-1 necessarily causes allergies, but if you have an excess mucus production because you've got excess inflammation that's not controlled with the alpha-1, you are going to get more problems with existing allergies. People have shown that asthmatic symptoms that are associated with alpha-1 do tend to improve when people get on replacement therapy. There may be some direct impact on the immune cells, and this is an area of research. People are trying to look at using replacement therapy as a way of preventing other types of immune disorders. And so certainly there may be a direct effect, but probably it's more important that we're talking the mucus that's there, that's excessive, and it's responding to just normal response. Allergies, it's always try to avoid whatever you can. For people, unfortunately live in places where stuff grows and you're allergic to everything that grows, it's pretty hard to avoid everything that's in your environment. But certainly, closing the windows at times and air conditioning and things like that you hate to admit, those do work. Again, there's some evidence that the symptoms do improve with replacement therapy, but probably nasal washes to get rid of all that excess mucus, to get the allergens pulled out from where they're stuck in the mucus, is going to help a lot more with alpha, because the mucus is going to be part of the problem. All right, so the lung function abnormalities, why did that occur? I don't know how many of you are familiar with what happens during a breathing test, but I'm sure many people have done them. And usually you breathe in and out, and you breathe very shallow in your resting state. Everybody here is moving very little air constantly because you don't need that much to sit still. When you take a big, huge breath in and force it all the way out, that's really what we're doing in a lung function test. And what we look at is the amount of air you breathe out completely in the test and the amount of that air that occurs in 1 second. And that gives us a good opinion about what's going on. In a normal person, you breathe out about 3/4 of the total air that you can breathe in and out in your lung within that first second. And people that have problems, not only do they have a smaller amount of air they can breathe in and out, but the amount they breathe out in 1 second is very limited. I showed you that one before. It was 20% or 18% and 50%. So anytime you're less than 70% in that first second, you have an obstruction to breathing out, and that's how we call these obstructive lung diseases. Again, it was that tethering, the airways closing on us, and that's what's causing the problem. The loops I showed you before were shifted over to the left. They also have this abnormal curve, and this is flow, so airflow out, and this is actually the size of the lung, the amount of liters in the lung that you're seeing. And that happens because all of these airways when you're breathing out are closing off and closing off and closing off, whereas a normal person, those airways close off much slower. And that's because, again, that tethering effect, the airways being held up by the lung, disappears. The other part that I didn't talk about, again, is that if you can't breathe all your air out, you're left with this state where you've got more air left in your lung at the end of the breath. Your chest wall can only expand so far, so you can fill it up to that space and make it a bigger lung, but you end up on that left shifted part of the curve where you're more air at the whole time, and you've got more air left in your lung when you're done breathing out. And I'll talk about that as how that ends up being the effect that's going to cause problems when you exert yourself. So again, shift it to the left, like I said. The curve is scooped here because you're not breathing the air out as well. It collapses down. Again, the percent that you can get out in the first second, this is 30%, so it is almost the exact opposite. The amount of air that comes out, this is less than a liter. You should be able to breathe out 3.5 liters of this person's height in a second. Is less than a liter total. And as we said, the shift is because the total lung capacity, which is the amount of air in the lung completely, if we look at it over here, is close to 8 liters, when it should only be about 6.5. And the residual volume, which is the air that's still present in the lung when you're done breathing out completely, here is 6 liters, when it should only be almost 2 liters. So big, full lungs that aren't breathing out properly, still able to oxygenate. And the reason this happens, the reason it's a problem when you exercise, is that there's a certain space within which you breathe. So most people are breathing in this little space at rest and then can expand their lungs to this size when they exercise. And that gives them a big expansion space, so when they exercise, they've got more lung they can utilize. If you take this residual volume, so the amount of air you can never breathe out, and you increase it to here, and you're resting around here, then you've only got this much space to breathe, because there's a limit to how big that lung can get when it fills into the chest. The wall only can expand so far. And you can imagine if you're stuck with this small space of breathing instead of this small space of breathing, you get into bigger problems. And the bigger problems happen mostly with exercise. So if a normal person is usually breathing in this range, and when they get disease over time, everything gets pushed up to this range, with this being the maximal size your lungs can reach, they're okay when they're sitting still because they're not approaching the maximal size. But as you start to exercise, this part of air that's still trapped in your lungs, still left, goes up and up and up. And so when you're trying to take those deeper breaths, you hit that limit of what you can fill your lungs, and pretty soon you're exercising in this little small portion that ends up being even smaller than where you're sitting at rest. And that's why the exercise gets to be such a problem, is you're not able to even bring in a normal amount of air as you try to expand it further and further, because there's more and more air stuck in the lungs, pushing against the rest of the lung. The last thing is, as we talked about the big flat lungs, it's a big problem because the muscles are shaped the way they are so they work. The curve of every muscle is so it pulls properly. And if you flatten off that part of the muscle, you make it so it doesn't work as well. So you're even worse off than you would think when you expand the lung, because you make all the muscles so they're not as functional and they don't work as well. And it makes it harder, or more effort, takes more energy to get the same amount of expansion as you would otherwise. All right, so Mr. AAT, his problem was he had emphysema. It's secondary to alpha-1 antitrypsin deficiency. Got his genotype. He's homozygous for the Z mutation, so the severe form. The emphysema is diffuse. It's worse in the lower lobes. He has areas of bronchiectasis, mostly in the lower lobes, possibly due to some prior infection. He has loss of elastic recoil, so the lung cannot stretch and pull back as it should. The sock sits in a funny shape and it's left. And there's extra mucus that's covering. That increases the resistance to the airflow, particularly in the small airways where they end up collapsing, obstruction to breathing out. It becomes frequency dependent, meaning the faster he tries to breathe or faster, deeper, the worse it gets. You end up with lungs that are full with air that won't breathe out properly, and because of that, the muscles don't work properly because they're stretched to the wrong shape. All of this results in the big problem, which is the lungs' function is to transfer gas. It becomes inefficient. You can't get the oxygen into your blood that you need, and then the areas lack blood flow. And there's the symptoms. You end up being short of breath with minimal activity. That's why it gets worse when you try to breathe deeper and faster, prolonged time to accomplish the task, and the requirement for supplemental oxygen. All right. Real quick, treatment is obvious, trying to avoid the things that cause the problem. It's pretty hard sometimes to define what the amount of problems are that are associated with your work environment. There have been studies where people looked at alphas that never smoked, and so certain jobs, particularly exposure to kind of inhaled organic compounds. This could be farming. This could be construction. It's hard to define for each person what is something you can't do. People come and ask me all the time, well, I'm in this workplace, is this a problem? It's hard to define the exact workplace issue, but certainly certain jobs, and it's probably inhaled organic compounds that irritate the lung and cause an immune response that are problematic. If you already have damage from prior smoking, then obviously that's going to continue to be a problem if the job is also an issue. If we can do anything to prevent lung injury, we know there's going to be more destruction to the lung. Vaccination's got to be high on our list. And then the oxygen. Where are the oxygen if you need it? It's hard for people to realize this. I don't feel like I need the oxygen. I don't feel better when I wear the oxygen. It really does save lives. That's the one thing we know. Replacement therapy. So, thankfully, they have done studies and found a way to measure lung density. I showed you that CT scan and how subtle it is. Unfortunately, it takes years to see the change. And the recent studies, they had people in 2 years, and they could show the replacement therapy kind of halved the amount of damage that occurred over that time. I know it doesn't sound like much. It takes a long time to see that damage. It still may not be enough for the European authorities to approve replacement therapy. But it does work. We now can see it. It just takes long trials. We're part of the SPARTA trial, which again is the same thing as trying to look at lung density. One of their arms is an increased dose. We don't really know how high you need to be to prevent damage, if there's any benefit of going even higher. We're just replacing to get people to the levels of a carrier. It's good, though, that we've got proof. We've got a way of showing that, and hopefully it'll help people in other countries that cannot get this therapy. The inhaled medications. So again, if you look at all of the symptoms, the inhaled medications are there really just to treat the symptoms. So they won't treat the progression of the disease, but if you think about if we open up the airways and we allow people to exhale better, when they go to exercise, there is going to be less mucus, less inflammation with some of the therapies. There is going to be more open airways, and they're going to have an improvement in the exercise tolerance. And so the inhaled medications really treat the symptoms, but especially these longer-acting agents, they probably improve the exercise tolerance by fixing that state so you're not stuck worse off. The reason oxygen works. So oxygen is not sensed by your system. This is people going down the coal mine and finding out that they died and having to bring the canary to let it die first. You don't really sense you're low in oxygen, but what oxygen does is that if your heart and your brain is starved of oxygen, you get remodeling and people die. And the initial studies that were done years ago just showed if you gave people that need oxygen, less of them died. So ultimately, although you might be able to exercise a little better, what we're really doing with it is we're preventing people from dying. All right. Still a lot we need to know. Unfortunately, the best way we have CT, it takes 2-year trials to be able to measure that people actually did better on a therapy that we really have known for a while was useful. If it takes 2-year trials for every therapy, it's going to be hard to get more therapies than the ones we already have. It's a long time. We need a better way to be able to assess change before it is severe. We need a better way to be able to get at that. Replacement therapy. So I said it have the change, but there was still decline in all the people that were on replacement therapy. We're not really sure why replacement therapy isn't enough. Why is there still some accelerated decline despite the fact that we've replaced what was missing? As always, needing to identify earlier. Finally, if there's any way we could repair a lost lung. And people are looking into this, but the lung is a problem because once it's destroyed, it's a delicate structure. It can't fix itself. The liver has some capacity to fix itself. As Jeff said, there's probably ongoing liver damage on everyone. It's just the liver has this ability to fix itself. The lung, once it's damaged, it doesn't really fix itself. Okay, so again, I'm always thankful for the foundation. They supported me some in my research. They're a great group. I love working with the research portion. Bob Sr., who's going to speak later today, trained me. A lot of what I know about emphysema today is thanks to Bob Sr. And then Steve Lafrax at WashU as well. I stole several of his slides from the med student lecture to include in here. All right, and hopefully I've left you guys time for questions.
How do you feel about the use of like Xolair? I know sub-Q.
Yeah. So I mean that's an allergy therapy,
Right.
And for people that have allergies and benefit from it, it obviously does work. It's not specifically for alpha, and certainly it is with its own problems, and that people can have severe allergic reactions to it. It probably, as a broad thing, I wouldn't say it's going to work for everybody with alpha-1. For people that have bad allergies, they do respond to Xolair. It's an effective therapy for specific types of asthma with allergic reactions. Yeah. I put everybody else to sleep. There were more questions about liver disease. Come on. I mean, I agree with Jeff. I think that the big deal is that we tend to separate it, and that's mostly physicians, because you see a separate doctor for your liver disease and your lung disease, and we tend to oversimplify that there isn't liver damage, and there probably is liver damage in everyone. It's just your recovery, your ability to recover, and certainly there are people that don't have lung disease or maybe don't have it yet, and there's a chance for some process to become problematic and make it happen in the future. So avoiding stuff when and it's nice for people that have their families and can tell them, you have a risk for having alpha-1, you should get tested because you'll know. It'd be great if nobody smoked, but obviously it should be a great motivation to know that you have this risk and you definitely should not smoke. So more awareness is beneficial, particularly if you have it. Make sure you tell your cousins, your relatives, your whatever. Somebody else probably does. People need to be tested, and the way they know they need to be tested sometimes is because they found out that their cousin had it. All right.
Are the carriers in?
Yeah, this is a really good question. So do carriers have any risk? So people that are MZs or whatever, there probably is some increase in risk. It's hard for us to quantify, but when they do very large studies of looking at carriers, there is a slightly increased amount of emphysema. And this goes back to how much alpha-1's enough. So we replace alpha-1 with the goal of getting people to a carrier state. The SPARTA trial is going to try to look at that, where they're going to give double the dose and just take a look to see if that causes any difference. But yeah, there probably is a risk. And as a carrier, it'd be good not to smoke. You've got half of what you need. There's no sense in trying to overwhelm the system. So yeah, it's hard to quantify how much, but when they take a look at large numbers of carriers, there appears to be a greater sensitivity to cigarette smoke.
There's great data actually from Professor McIlvaney's research lab in Dublin.
Yeah.
And I know it's on the Alpha-1 Foundation website. If you do a search, you'll definitely find lots of data there.
Yeah, but just to put it simply, the carriers are at risk.
Get my exercise it.
Okay, I have a question. You said that, and we know that exercise helps us to loosen the mucus that's in the airways. My question is, how do I know if, especially like if I'm exercising in outside and the temperatures are like 50 degrees and there's a lot of allergens in the air and everything like that, how do I know if the excess mucus that I'm producing is stuff that I'm loosening or I'm producing more because of the other stuff? Is it a matter of like the color of what's coming out, or
no.
how do I know?
No. I mean, so I mean, all mucus is good and all mucus is bad, right? So this is a problem. Like we think if we could just get rid of the mucus, everybody would be better. But actually, you're producing the mucus because there's too much inflammation in the first place, right? So all mucus is good. Mucus itself captures the allergens, it captures the inflammatory stuff, and so it is preventing that stuff from hurting you. And so all mucus production is good, and then all mucus is bad because all mucus is plugging up the airways, right? And so your question is as well, if I go out and I exercise and that causes more mucus, or am I hurting myself? But I think the answer is in the end that mucus is being brought up. So even if you produce more, as long as you are bringing it up and not leaving it in there, you're doing yourself good. For those of us that are suffering a little excess mucus right now from a cold or something, it doesn't feel like it's helpful. But the mucus is actually all beneficial. It is fighting the elastasis in some way, and it only helps if it gets brought up and out.
Just kind of tying back the lung and the lung and liver being together. Do you recommend all your lung patients to see a liver doctor at some point?
We don't. I mean, I think in essence, the liver disease predominantly occurs when people are young, and so the most severe parts of the damage occur when you're young. Once you get to a point that you can grow out of it, usually the liver damage doesn't progress as much because there's that healing capacity. People that have signs, and we, usually check on a regular basis the liver function test to make sure there's not an alteration or something that looks like progression. Typically, it doesn't occur very quickly. It can occur quicker if there is a sudden injury or sudden damage. But yeah, usually, unless there is a problem, just monitoring it to make sure it doesn't change is the issue. And anybody could do that. Your family physician can check yearly labs and know that there's a change.
Do you test everyone that comes into your office that has COPD?
Yeah. And I actually work in a hospital, and I try to ingrain this in the house staff. The truth is that test is really cheap. Not sending a genetic test, but just sending a blood level. And it seems like it's crazy. People are like, well, why should I send it? Well, do you know it's been sent? And if you don't, then you can send one. It's really not that expensive. The genetic testing would be more expensive, but a simple blood test is not that big a deal. And often we're drawing blood for something else. You'd be amazed at the amount of times you say it, and they're like, really? I mean, this can't be. You're like, well, really, how expensive was that? Did that cost any more than checking to see if they were anemic? Not that much more. It's really, it is cheap. It's a valid screen. And so, yeah, I try to ingrain in people that if you don't know it's been checked, check it. And then after you check it, document that you've checked it, and you'll know in the future.
What test should you ask the doctor to do?
Just an alpha-1 level. And any, it's amazing because it is not a highly specialized test. They do these protein electrophoresis all the time, and it's just the alpha spike. It's the first big spike.
I want to know if they should do any further testing for like my kids. Before I knew that they had to be carriers, I had them tested, and the doctor came back and said they're fine.
Right. So their levels are going to be normal, or within the normal range, and I think that again, that's the problem with the screen is you won't identify carriers.
Right.
The carriers, obviously, if you have disease, all of your children are carriers.
Right. But what I'm saying is I've heard people misdiagnosed.
Yeah.
Because they said they took the test and no, their levels were high, but
Right.
That's why I'm wondering if they're doing that.
Yeah,
Is it the phenotype that should be done with that test too? Or?
Yeah, no, I mean, I usually suggest everybody get the level, because as long as the level's normal, you should be fine. You should have enough protective capacity that you're not going to run into issues. I mean, nobody should smoke. I'm not telling you, if your level is normal, you can go ahead and go out and smoke.
And I'm confused about that too, because every carrier that I know has lung problems. I mean, I know,
Every carrier you know.
I have a son that's 15 and a son that's 25, and they both have lung problems. And then everybody in my family that is carriers have lung problems.
Yeah.
My co-leader of our sport group has lung problems, and she's a carrier.
Yeah.
So.
Yeah, no, I mean, I think, again, the quantity of lung disease in people that are carriers probably has to do with exposures, and it's pretty hard to quantify who's going to get problems and who's not. If you know you're a carrier, it's easy to say, avoid that. The quantity of disease that's out there beyond is hard to know. And again, it might be that we need to adjust what we consider a safe level, and it has to go up a little higher. But currently, the best and easiest way to screen is something that's cheap, something that's available, and something that every hospital can do without even thinking twice. And getting an alpha-1 level and knowing it's normal can at least move you to other directions.
I do have a question. So you're testing for levels at the hospital level? So a sick patient?
Yeah.
Do not have an artificially high level?
When you're sick, So she's saying when you're sick, can your levels be elevated? And people can respond, and you can push your level up a little bit when you're sick.
Would you miss people?
You would probably miss some. But the levels are so low in people that have severe deficiency that it doesn't push it up enough that you're going to cross the threshold. It really is low. People that have severe mutations, those levels are quite low compared to what the average person is. And so even within the range of error of that test, it's hard to push it above.
Would you agree with secondhand smoke as well?
Oh, yeah. I mean, again, I think there are people that are at job exposures that probably are organic inhaled compounds. I mean, secondhand smoke is terrible. You cannot, again, quantify the degree of people that have problems due to secondhand smoke. But it needs to be avoided. Probably even in carriers, it needs to be avoided. It's a problem.
All right. And again, in the interest of time, and I want to give you guys a break, huge thank you to Dr. Atkinson.